And we have a couple of vignettes for pain syndromes. Let me now read vignette number 21. A 60-year-old man complains of extremely severe, sharp shooting, like a bolt of lightning, pain in his face that is brought about by touching a specific area. Lasts about 60 seconds. His neurologic examination is normal, but it is noted that part of his face is unshaven because he fears to touch that area. This is a classic. This is what the lay public refers to as tic douloureux. The fancy name is trigeminal neuralgia. Trigeminal neuralgia happens to this type of patient. This is the right age group. It is classical that the neurological exam is normal. Hard to tell what it is that is bothering the trigeminal nerve, but this is a very terrible problem for the patient who has it. It's a source of a great deal of pain and suffering. Now, even though we don't think that there is a lesion that can be identified that happens to be impinging on the trigeminal nerve, most physicians in this country, perhaps for medical legal reasons, rule out organic lesions with an MRI. So if you find offered as an option to do an MRI on this gentleman, that would be a correct answer. The treatment relies at first on anticonvulsivants. And if necessary, we can do radioablation, a very fancy technique that by the selective use of heat can kill the pain fibers of the trigeminal nerve while leaving the sensory fibers intact. And then we move to vignette 22. Several months after sustaining a crushing injury of his arm, a patient complains bitterly about constant burning, agonizing pain that does not respond to the usual analgesic medications. The pain is aggravated by the slightest stimulation of the area. The arm is cold, cyanotic, and moist. This is a pretty good description of causalgia, also known as reflex sympathetic dystrophy. A successful sympathetic block helps us confirm the diagnosis. So if these symptoms go away by doing a block of the sympathetic ganglia in the neck, then we know we're on the right track, and then that could be followed by surgical sympathectomy as a more permanent curative intervention. And that brings us to the end of the neurosurgery portion.